Chapter 19, Treatment of Heart Disease and Stroke. Heart disease is the number one cause of death in the United States. Coronary heart disease is the leading cause of heart attacks and is a risk factor for stroke and heart failure. Heart failure is a clinical syndrome in which the heart is unable to pump blood at a rate necessary to meet the body's metabolic needs. Disease, lifestyle, and drugs can contribute to the onset or aggravation of heart failure. Kidney dysfunction, diabetes, metabolic syndrome, ischemic heart disease, hypertension, hypothyroidism, hyperthyroidism, bradyarrhythmia, tachyarrhythmia, pulmonary embolism, HIV and AIDS, and myocardial infarction can contribute to heart failure. Non-steroidal anti-inflammatory drugs, for example, worsen edema and interfere with the effect of drugs used to treat heart failure. Heart attack is called a myocardial infarction, which produces symptoms that are similar to those of angina. Table 19.1 shows the difference between the characteristics of timing, location, and quality versus a myocardial infarction and angina, which is just chest pain. Strokes occur when brain cells are deprived of oxygen or are damaged by sudden bleeding into the brain. Approximately 50,000 will have a mini stroke, a transient ischemic attack. Persons who have had one stroke and recover are more likely to have another. All strokes produce similar symptoms. Symptoms appear suddenly. So table 19.2 shows symptoms of a stroke. For the limbs, there's numbness or weakness of the arms or legs, difficulty walking, loss of balance or coordination, ears, eyes, nose, and throat, facial numbness or weakness, impaired vision, cognitive, difficulty understanding speech, confusion, and other dizziness and severe headache. Ischemic strokes are caused by oxygen deprivation. Anoxia occurs when arteries are obstructed, causing brain infarcts. Thrombotic stroke is caused by an enlarged thrombus or blood clot. Embolic stroke is caused by embolus, a traveling clot or plaque that has been dislodged. Blood clots are the most common cause of strokes. Hemorrhagic strokes are caused by bleeding in the brain. It may be the result of an aneurysm, a weakened spot of the artery wall that has stretched or burst, or filling the area with blood and causing damage. TIAs are also known as mini strokes. They typically last only a few minutes and symptoms usually resolve within an hour. Heart failure may affect the left side of the heart, the right side, or both sides. Left side heart failure reduces the volume of oxygen and nutrient-rich blood pumped from the left ventricle to the rest of the body. The ejection fraction, the percentage of blood ejected from the left ventricle with each heartbeat, is reduced. Right-sided heart failure reduces the capacity of the heart to fill with sufficient blood and pump the blood to the lungs to pick up oxygen. Persons with right-sided heart failure may have swelling in the legs and ankles. Fluid accumulation can result in weight gain and increased urination. Persons with right and left-sided heart failure may experience shortness of breath and feelings of fatigue. Natriuretic peptides are hormones that also play a role in cardiac physiology. Atrial natriuretic peptide and brain natriuretic peptide are both found in cardiac tissue and are released in response to excessive stretching of heart muscles. There are 4 stages of heart failure. Heart failure may also be described by functional class. So we have them here, A, B, C, and D, and 1, 2, 3, and 4. Stroke and myocardial infarction occur when the blood supply to the brain or heart is interrupted. Cells become damaged from ischemia or die when they are deprived of oxygens and nutrients. Vascular inflammation is a cause of atherosclerosis. Chronic inflammation of the arteries that supply the heart and brain can also lead to stroke and myocardial infarction. The risk for chronic vascular inflammation increases with age. Atherosclerosis can block blood flow through arteries. Arteriothrombosis can clog arteries and is triggered by atherosclerosis. Some non-modifiable risk factors for cardiovascular disease are age. Age is a significant risk factor for stroke and myocardial infarction. Although stroke can occur at any age, the risk increases exponentially with each increasing decade. Gender is an important risk factor for stroke. Men are 1.25 times more likely to have a stroke than are women, yet strokes in men are less likely to be fatal. This is probably because men are often younger than women when they have a stroke. As with a stroke, men have a greater risk for heart attack than do women. However, older women are more likely to die within 3 weeks of a heart attack than are men. Modifiable risk factors for stroke and myocardial infarction are smoking, alcohol consumption, and diet. Smoking promotes atherosclerosis, increasing clotting factors in the blood, stimulates vasoconstriction, and weakens the endothelial wall. These factors contribute to the risk for ischemic stroke and hemorrhagic stroke. Excessive alcohol consumption and binge drinking can lead to an increase in blood pressure and can reduce platelets, which increase the risk for hemorrhagic stroke. After heavy drinking, a rebound effect occurs that increases platelets and thickens the blood significantly, increasing the risk for ischemic stroke. A diet high in cholesterol may increase the risk for atherosclerosis, and a diet high in salt can aggravate hypertension. Hypertension increases the risk for stroke 4 to 6 times above that of persons without hypertension. Atrial fibrillation, a rapid and irregular beating of the atrium chamber of the heart, can increase the risk for clots. If the clots are dislodged, they can block an artery, leading to stroke or myocardial infarction. Malformations of the heart valves can also lead to clot formation, increasing the risk of stroke or myocardial infarction. High cholesterol levels are a risk factor for stroke and myocardial infarction. Cholesterol may be in the form of high density lipoproteins and low density lipoproteins. LDLs can build up within arteries and harden. This hardened material is called plaque, and it can impede blood supply to the heart and brain. Plaque can become dislodged, interrupting blood supply and causing stroke or myocardial infarction. Diabetes also increases the development of atherosclerosis and therefore is a risk factor for stroke and myocardial infarction. Infection is a risk factor for stroke and myocardial infarction. The immune system response to bacterial and viral infections is to release cytokines, leukotrienes, macrophages, and other infection-fighting substances that increase inflammation. Inflammation can increase the risk for ischemic and embolic stroke. Most of the drugs used in heart failure focus on treating symptoms, underlying causes, and factors that worsen heart failure. Many of the same drugs administered in the treatment of hypertension are also used in the treatment of heart failure. They include diuretics, aldosterone antagonists, beta blockers, ACE inhibitors, and angiotensin II receptor blockers. Atherosclerosis and arterial thrombosis are important risk factors for stroke and myocardial infarction. Drugs that control the buildup of lipids and plaque and drugs that reduce the formation of blood clots are administered to prevent stroke, myocardial infarction, and acute coronary syndrome. The cardioglycosides are the oldest class of drugs used in the treatment of heart failure. Digitalis is a cardioglycoside derived from the foxglove plant. Digoxin is the only commercially available cardioglycoside in the US. So we have lifestyle modifications recommended for people with heart failure in box 19.1, all of which we've pretty much already talked about. Cardioglycosides such as digoxin have a positive inotropic effect on the heart. They increase the force of myocardial contractions. The greater force of contractions increases the cardiac output and reduces heart size. Automaticity is the spontaneous depolarization of heart cells. Digoxin produces significant effects on the heart's conduction system. It decreases conduction velocity through the atrioventricular node, prolonging the time between contractions. The number of depolarizations is reduced too. A further description of digoxin's effect on the conduction system is described in chapter 20. Digoxin is marketed in several different dosage forms: tablets, oral solutions, and parenteral solutions. The bioavailability of digoxin differs among commercial manufacturers, so attempts should be made to consistently dispense the same manufacturer's product each time. Food can decrease absorption. The peak effect of digoxin occurs between 1.5 to 5 hours after administration, and the half-life is approximately 36 hours. Digitalis has a narrow therapeutic index. The dosage range between the therapeutic dose and the lethal dose is narrow. Therefore, patients should watch for signs of digitalis toxicity. According to the current AHA ACC recommendations, digoxin is not recommended for the treatment of HFrEF in men or women who also have sinoatrial or AV block. DigiFab is an antidote for digoxin toxicity. So if for some reason you got the wrong amount, that is what we would give to decrease the medication effects in your body. So you can see we have quite a bit of different dosage forms and strengths. And then for the antidote, it's just available in a lyophilized powder for reconstitution. The diuretics are administered to treat volume overload. They also lower blood pressure and reduce pulmonary edema and swelling in the ankles, legs, and feet. When diuretics are administered, potassium levels should be monitored because loop and thiazide diuretics can cause hypokalemia. Hypokalemia can increase the effects of digoxin, leading to toxicity. The drug summary table provides doses used for the treatment of heart failure. Aldosterone is a hormone that promotes sodium retention and water accumulation. Spironolactone and eplerenone are aldosterone antagonists. They are administered with other drugs to increase sodium and water levels. The beta blockers reduce the heart rate, lower peripheral arterial resistance, lower blood pressure, and decrease the workload of the heart. They also reduce left ventricular hypertrophy. Studies show that beta blockers can lower the risk of mortality associated with HFrEF type heart failure. The ACE inhibitors are one of the few classes of drugs used in the treatment of HFrEF type heart failure that have been shown to reduce mortality. They reduce left ventricular hypertrophy, improve diastolic filling, increase cardiac output, and reduce peripheral vascular resistance. The ARBs are also administered for the treatment of heart failure. Isosorbide dinitrate and hydralazine are used in combination for the treatment of heart failure for their vasodilating effects. This reduces peripheral resistance along with cardiac preload and afterload. When combined with nitrates such as isosorbide dinitrate, hydralazine can decrease mortality and effectively reduce cardiac congestion. The two newest agents marketed for the treatment of heart failure are the angiotensin receptor neprilysin inhibitor Entresto and Lacorna, which is an IF channel blocker. Clotting is a normal process without which one would bleed to death if any injury occurs. Drugs that control hemostasis are administered to patients at risk for heart attack or stroke in order to prevent blood clots from forming in an artery. Drugs that control the rate of clot formation and clot dissolution are classified as antithrombotics. Antithrombotic drugs include agents that inhibit platelets, anticoagulants, which lessen coagulation, and fibrinolytic agents that dissolve existing clots. Antiplatelet drugs produce their effect by interfering with steps in the clot formation process. When an injury occurs, platelets cluster at the site and start to stick to the damaged cell wall. Although aspirin is a non-prescription drug, it is effective for the management of post-myocardial infarction and stroke. In addition to its antiplatelet activity, aspirin blocks the enzyme cyclooxygenase, reducing plaque formation. Aspirin inhibits prostaglandin synthesis, which decreases TXA2. Bleeding is a common side effect of antiplatelet drugs. Black, tarry stools, blood and vomit, urine or stools, nosebleeds, and red or purple spots on the skin may indicate bleeding. So we have antiplatelet drugs, aspirin, clopidogrel, quercetin. And then we also have Agranox, which is a combination of quercetin and aspirin. And then we have our glycoprotein 2B 3A inhibitors. All of these, which are available only as solution for injections, Aggrastat, Integrilin, and RioPro. Heparin is an anticoagulant that is derived from pig intestines or cow lungs. The extraction process results in a mixture of fragments of varied molecular weights. Low molecular weight heparins are produced by separating the heparin fragments. Heparin and LMWH are administered parenterally to prevent the formation of blood clots. Their uses include prevention of acute ischemic stroke, prevention of clotting medical devices, prevention of pulmonary embolisms, early treatment and prevention of myocardial infarction, and treatment of deep vein thrombosis and arterial thromboembolism. To test the effectiveness of heparin and to determine whether dosage adjustments are necessary, an activated partial thromboplastin time test is performed. This test measures antithrombic activity. The APTT is a test of the intrinsic anticoagulation pathway. It tests the time it takes for the blood to clot. Heparin and LMWH are administered by intravenous or subcutaneous injection. Oral absorption is poor. Warfarin and dabigatran are orally administered anticoagulants. Warfarin is used to prevent pulmonary embolism, thrombotic and embolic stroke, acute myocardial infarction, and AFib. Dabigatran is the first oral anticoagulant to become available since the approval of warfarin more than 50 years ago. That's pretty interesting, kind of cool, right? Dabigatran is an oral direct thrombin inhibitor where warfarin interferes with the formation of vitamin K dependent clotting factors. Prothrombin time is a test to determine how well warfarin is working to prevent clotting and to determine whether dosage adjustments are necessary. This test is also called an international normalized ratio test, INR, and that is how they find out how much medication it you need for your body. Pharmacy technicians should remind the patients taking anticoagulants to seek the advice of a pharmacist before taking prescription and non-prescription drugs. Many drugs interact with anticoagulants, causing serious bleeding or hemorrhage. Anticoagulants should not be combined with antiplatelet drugs, aspirin, NSAIDs, vitamin supplements, and herbs. Overdose of warfarin or heparin can result in hemorrhage or death. Overdose may be treated by giving a blood transfusion. In some cases, warfarin overdose can be reversed by the administration of vitamin K. Heparin overdose may be treated by the administration of protamine sulfate. Warfarin tablets are color-coded to reduce med error. So you can see all the different strengths of warfarin. Those are all different colors. And then for Fragmin, we have pre-filled syringes and solution for injections. And Pradaxa is dabigatran, which is the medication, the newest one since warfarin in 50 years. Thrombolytics are called fibrinolytics, are drugs that can dissolve blood clots. The drugs are administered in the early stage of stroke to open blood vessels in the brain. They are also used in the treatment of acute myocardial infarction. Thrombolytic agents currently in use in the United States are alteplase and tenecteplase. Retaplase is marketed in the United States only. All of them activate the fibrinolytic system, the body's normal system for preventing excess clotting. Alteplase is a tissue plasminogen activator produced by recombinant DNA technology. Thrombolytics work rapidly. They can reopen an obstructed blood vessel within 90 minutes of administration. The thrombolytics must be administered within the first 1 to 3 hours after a stroke occurs. Therefore, the risk of hemorrhage exceeds the benefit of administering clot dissolving drugs. So we have all of these, which are all injections. So we need them to work fast. Hyperlipidemia is a disorder associated with dysfunctional fat metabolism. While fats are necessary to form steroid hormones, bile, prostaglandins, and cell membranes, excessive buildup in the blood is a significant risk factor for stroke and heart attack. LDL is known as bad cholesterol because elevated LDL cholesterol levels promote plaque buildup in arteries, atherothrombosis, and vasoconstriction. All increase the risk of cardiovascular disease and stroke. Recent evidence has shown that increasing HDL good cholesterol, in addition to reducing LDL cholesterol, can lower the risk for cardiovascular disease, even in persons who have normal HDL levels before starting HDL drug therapy. Lipid-lowering drugs interfere with steps in the lipid metabolism pathway. They may affect cholesterol synthesis or elimination in bile or act on LDL metabolism. Although the mechanisms of action may vary, all lipid-lowering drugs reduce LDL and triglyceride levels. So all hydroxymethylglutarol CoA inhibitors have the common ending of statin, and you'll usually hear them referred to HMG CoA reductase inhibitors. They're also called statins. HMG CoA reductase is an enzyme that is involved in the final step of cholesterol synthesis. Statins increase LDL clearance. They are more effective than other lipid-lowering drugs at lowering LDL. They have been shown to only minimally elevate HDL above pre-drug levels. Simvastatin and lovastatin are pro-drugs and must undergo metabolic changes before they are pharmacologically active. Common side effects include diarrhea, gas, headache, joint pain, nausea, vomiting, upset stomach or pain, and tiredness. Serious life-threatening muscle disorders that may be caused by statins and myositis and rhabdomyolysis. Statins can also elevate liver enzyme, resulting in liver dysfunction. So we have the statins here in this chart: atorvastatin, fluvastatin, lovastatin, pravastatin, rosuvastatin, simvastatin, pitavastatin, and then we have a combination of ezetimibe and simvastatin, which is Zetia and simvastatin together for Vytorin, atorvastatin and amlodipine, which is Caduet, and atorvastatin and ezetimibe, which again is Zetia. Fibric acid derivatives or fibrates are regarded as broad-spectrum lipid-lowering drugs. Fibrates increase the clearance of very low-density lipoproteins. Fibrates are less effective than statins at reducing LDL and in elevating HDL. Gemfibrozol is one of the fibric acid derivatives, fenofibric acid and fenofibrate. Bile acid sequestrants promote intestinal clearance of cholesterol. They are administered to reduce LDL levels. They are not absorbed and therefore are the drug of choice for use in pregnancy. So if you have high cholesterol and you're pregnant, they're not going to give you a statin. This is what you would be on. So we have Prevolite, Welchol, and Cholestid. Those are the different bile acid sequestrants. The cloestramine is a powder for reconstitution. It either comes in a packet or a little jar for scooping it out. Niacin is a vitamin B3. It is the most effective lipid-lowering agent for increasing HDL. So that's a nicotinic acid derivative, niacin. You can buy some strengths over the counter, but they're not exactly identical to niacin, Niacort, or slow niacin. All right, now we have usual dose and dosing schedule for drugs used in the treatment of cardiovascular diseases. Then we also have some of the warnings. So for digoxin, take as directed. Do not skip or exceed doses. If you miss a dose, take it as soon as you remember, unless the next dose is scheduled to be taken in less than 12 hours. For the IF channel blocker, avoid pregnancy. And again, we just have the normal dosages listed here for each drug, which is kind of nice. Could help you in preparing for MedList quizzes in general, not just for this one. For antiplatelet drugs, we're going to report signs of bleeding, do not shake. For the medications that are suspensions, avoid pregnancy with aspirin, protect from light for tirofiban, store at room temperature tirofiban, dipyridamole, take that on an empty stomach, and swallow whole, do not crush or chew aspirin and dipyridamole. For the anticoagulants, we need to report signs of bleeding, avoid OTC medications without medical supervision, avoid pregnancy and warfarin, swallow whole, do not crush or chew. For the dabigatran, protect from moisture, dabigatran, and store in manufacturer's original packaging, dabigatran. So that's another thing to know if you work in the retail world. We're never going to open up those bottles and pour into a vial. It comes with 60, exactly how much the patient needs for a month. We're going to leave those in the manufacturer's original container and label that. For thrombolytics, do not shake, all of those. Refrigerate reconstituted solution, stable for 8 hours after reconstitution. For the statins, avoid grapefruit juice for ortorvastatin, lovastatin, and simvastatin. Pregnancy should be avoided in all, and any of the extended release should not be chewed. For the fibric acid derivatives, take on an empty stomach. For the bile acid sequestrants, take 1 hour before or after other drugs. And for niacin, take with food. And for the combination of Zetia and simvastatin, that should be pregnancy should be avoided, and so should grapefruit juice. For the miscellaneous clustering lowering agents, we have Zetia, which only comes in a 10 milligram tablet.